Hello and welcome to another episode of the AtheroTalk podcast, the podcast series hosted by the EAS Young Fellows. My name is Laura Gaiță from the University Clinic of Diabetes, Nutrition and Metabolic Diseases in Timișoara, Romania, and I will be your host for today's episode, recording during the EAS 2025 Congress in Glasgow, UK. We are privileged to have an exceptional guest with whom we will discuss about cardiometabolic medicine with a focus on cardiovascular prevention, lipid disorders, and how it can deliver an improved care for our patients with dyslipidemia and specifically FH. Professor Gerald Watts is a senior consultant physician, full professor, and chair of the Familial Hypercholesterolemia Australasian Network. He studied at Imperial and King's Colleges in the University of London and was a scholar at Wolfson College, Oxford University. He is currently director of the Cardio-metabolic Service, Departments of Cardiology and Internal Medicine, and professor of Cardio-metabolic Medicine at the Royal Perth Hospital and the University of Western Australia. Professor Watts is actively involved in teaching and supervises several MD and PhD students and postdoctoral fellows. He has authored over 730 published works and is on the editorial board of Atherosclerosis, Metabolism, Journal of Clinical Lipidology, American Journal of Preventative Cardiology, Current Opinion in Lipidology, and Current Opinion in Endocrinology and Diabetes. So hello, Professor Watts. It is a real pleasure to have you here today to discuss your trajectory and your opinion on the future of atherosclerosis research. On behalf of the EAS Young Fellows, I would like to thank you for accepting our invitation.
Thank you very much indeed, Laura. It's my pleasure.
In this series of interviews, you would like to give our listeners the chance to get to know you more personally and about your research and academic career. So could you please introduce yourself to our listeners? Who is Gerald Watts?
Gerald Francis Watts is my name. I work in Perth and Western Australia, but originally I'm European. I'm a British subject, and I went to school in the United Kingdom, and then to university in London, and at London's Imperial College, and I trained in teaching hospitals in the United Kingdom, and was interested in science and the scientific basis for medicine as a medical student. I did a Bachelor of Science Honours, and then in parallel with my training, I did a doctorate in medicine and a PhD. So it was quite clear that because of a family history of diabetes and obesity and familial hypercholesterolemia, my interest would be cardiometabolic prevention. So my doctorate in medicine was in diabetes, specifically diabetic nephropathy, and I was working at the Wessex Regional Renal Unit in Southampton, actually, where I did the University of Southampton, and then in London, I worked in lipid disorders, diabetes and cardiology, and I did a PhD on the regression of coronary artery disease using quantitative coronary angiography, using diet and a cholesterol-lowering agent known as cholestyramine, which is a bile acid sequestrant. And we could show quite clearly there that a combination of diet and LDL cholesterol lowering actually improved the progression of coronary disease really over 3 years, a paper that we published in the Lancet, really. So I was interested in research all the way through, but at the same time, I was a clinician. So I think the important thing for me was always to keep my training broad, training in general medicine, training in gastroenterology, cardiology, diabetes, and renal medicine, and neurology. So it's important to mention that because as a major interest in diabetes, you cannot do diabetes without knowing general medicine, really. So those skills that I developed in renal medicine and in diabetes, together with the skills that I obtained in lipid disorders, stood me in good stead to think about the notion of cardiometabolic medicine, which wasn't really known then, but it was clear in my head that you couldn't really practice one in isolation with the other. And I was fortunate to work for people who encouraged me to think quite broadly. Professors of renal medicine, professors of lipid disorders and diabetes, and I could straddle those specialties and felt very comfortable only because I had done general medicine and I could relate to the other disorders that people had, really. And so specifically, my mentor at the University of London was Professor Barry Lewis from the Royal Postgraduate Medical School, and then over at St. Thomas's, Professor Peter Sogson, who was a professor of diabetes and endocrinology, and both of whom were my mentors at Guy's and St. Thomas's. My period in renal medicine was very much very educational beyond renal medicine, because my professor was very much interested in the philosophy of science and scientific writing, actually. So we spent quite a bit of time discussing the whys and wherefores of questions and whether they were useful or not, and how to construct hypotheses, how to argue and construct arguments, really. And in writing, I think from him I learnt, how to write very precisely and very logically. And from my other mentors, how to write, how to frame writing in a very clear way, actually. So I'm very grateful for that. So for many years, of about 10 years at the University of London in an academic position, and then for personal reasons, because my wife was from Australia, from Perth, and from Sydney, the families where she wanted to relocate to another country, which was a bit of a shock to me because my plans were always to stay in the United Kingdom. And then at the age of 30, I think it was 39, over 30 years ago actually, I had to relocate. The job came up in Perth in Western Australia. Is probably the best offer of the job, the best conditions, because I was integrating into a group of clinicians and scientists who were quite like-minded. Many of them had qualified over here in the United Kingdom. Professor Lawrence Balin, who was a professor of hypertension, and they wanted someone with an interest in diabetes and lipid disorders to join their group and lead that particular group. So, the offer was very good and the weather was very good. But I was a bit, when you're making a transition in your life to change from one situation to the other, when you have a clear head. I mean, I wanted to be, heading a group, being a professor in London or Oxford or Cambridge or Bristol or somewhere like that in Europe, really. I never thought I would have to relocate at a time it's a tipping point for me in my life, and to another country, completely new, with new standards and a place to. So at the age of almost 40, I had to reinvent myself again, and had to close a lot of the research I'd started here, but keeping the links open, actually. And in a sense, once you're isolated in a place that's far from everywhere else, such as you learn that you have to collaborate in order to achieve what you wanted to do. So I had to relocate to Australia from London. I had some grants here, which I could take with me, and then built up a research program in Perth in Western Australia, the most isolated capital city in the world, actually. So it's not like here that you can go from one place to the other. Now, I was fortunate in that because I was interested in lipid disorders, I was fortunate that the professor of physiology there had actually discovered the chylomicron remnant, which is the breakdown product of a fat meal. And that for me was important, really, because he had his own research group of young investigators who wanted clinical meaning. I gave them clinical meaning to the projects that they were doing. So we could combine, mechanistic, physiological in vivo studies with the sort of hypotheses that they were generating in the laboratory, with respect, for instance, to the impact of obesity and diabetes on lipid metabolism. So a lot of the work that I did when I started there was trying to understand the mechanisms whereby insulin resistance that disturbs lipid metabolism, and specifically the consistent finding that we found using stable isotope tracers really were that the hepatic availability of lipid substrates, cholesterol or fatty acids and triglycerides, govern the rate at which the liver secreted ApoB100 actually, which was the pressure head on the production of triglycerides, the production of LDL actually, and that you could correct those abnormalities actually with lifestyle measures and a variety of drugs really. So that was useful too, and I was fortunate too that because I had a background in cardiology, I could set up technologies to examine arterial function in the peripheral circulation initially. So I had effectively two programs going: a program in metabolism using isotope tracers, and another program looking at arterial function in the forearm microcirculation to look at the mechanisms of arterial disease in vivo and the effect of intervention. So a lot of work. In addition to that, to running looking general medicine, doing acute general medicine, a diabetic clinic, hypertension, lipid disorders. There wasn't much time for anything other than for sailing, actually. My interest was also sailing. I had several children that I also had to look after, actually. But what I would say that, over time, I was fortunate in getting a lot of good people to work for me and attracting international fellows from the NIH, Professor Hugh Barrett, Richard Chan, too, who came to work for me from Hong Kong. And, we did set up quite a productive unit in Perth in Western Australia, whilst maintaining my international associations with former colleagues in the United Kingdom, Gilbert Thompson at the Royal Postgraduate Medical School, and also in the US too, and in Canada. So I think the international collaboration was quite important to, the trajectory that I took really, and I suppose really because you are so isolated in Perth, really, you don't tend to involute, you tend to go out. So we did also some work in South Africa. Many of the hypotheses in vivo that one had about how lipid metabolism was affected could be tested in South Africa with Derek, not with Derek Rahl at that stage, who's now become a collaborator, but with David Murray in Cape Town, because they had so many genetic disorders really that affected lipid transport. And by studying those individuals, and with due consent, you could test your hypotheses quite effectively. So yeah, I mean, a lot of time was spent, raising money and like yourself, looking at mechanisms initially. But as time moved on, you asked yourself, well, what is, how translatable is this really? What impact is it having on clinical care? I think when you're working on mechanisms of disease, the jump to there of evidence at the physiological mechanistic level, the jump, the trajectory to clinical practice is quite long. So in time, as we moved along, one of the things that did worry me from a clinical perspective there, Laura, it is Laura, isn't it?
Yes, it is.
Laura, is that there were too many different types of clinics, really. I didn't see, and I'm talking here, I'm going to give because I'm interested effectively in the thing that I call complexity science, really, but also complexity science as it applies to clinical services, really. So, I mean, for example, lipid metabolism using tracers is complexity science, but the reorganization of medical services is also complexity science and how you go around doing this. But it struck me that didn't make much sense that we should have in a clinical service in hypertension, a clinical service in lipid disorders, a clinical service in obesity, diabetes, and a cardiac service, really, and that for that reason, as time went on, I thought that, well, why don't we just bring them all together, actually, and run a cardiometabolic service that would cover, the needs of all those specialties in one. And that's exactly, what we did in time. But what crystallized that was that is having a condition that you could go to management and say, look, this condition is a very high-risk condition. This condition is susceptible to inaccurate diagnosis. And if you actually treat it in a standard way, you can lower the risk and it's cost effective. And that's how we came to familial hypercholesterolemia. I mean, familial hypercholesterolemia was the poster child of, what we could do, because this was the time, probably about 15 years ago, when genetics was more prevalent, when you could make accurate diagnoses. And familial hypercholesterolemia is the only metabolic condition, really, genetic condition, for which there is extreme evidence, really, for reduction in risk with intervention, plus evidence that it's cost effective. I mean, there are three tier 1 genetic conditions at the Center for Disease Control in the US. These are hereditary conditions that affect breast cancer and bowel cancer, but also familial hypercholesterolemia. And that's a high-impact condition. You can make an accurate diagnosis, and you can reduce risk with intervention at an early stage with a statin. So we did a health economic evaluation of familial hypercholesterolemia and then put it to management that this was so effective that they should fund this as the core condition of the cardiometabolic services. And it's around that, should I say, by opportunity, that we built a cardiometabolic service around the services that we had for familial hypercholesterolemia.
And how do you envision this specialty or subspecialty about cardiometabolic medicine? What should be the key points in its potential curriculum, and what should we learn about, or how should we develop it?
Yeah, there are various models for that, but I mean, it varies by countries. There are some countries, I mean, it's not a recognized specific specialty anywhere at the moment, because you train in cardiology, you trained in diabetes, you trained in renal, and lipid disorders, maybe in general medicine, endocrinology. It doesn't seem to be anywhere at the moment, really. It's how to actually put it together, right? And I mean, I'm fortunate in that I set up the first cardiometabolic service in Australia, and then because of that, I was appointed a professor in cardiometabolic medicine, and that's what we practice, really. We try and bring it all together by having people who think quite broadly about things. General practitioners who work in my clinic, hypertension experts, endocrinologists, and dietitians, evidently, people with genetic expertise. And it's difficult to bring it all together, actually. But beyond that, really, we do have a lot of our services are actually involve the clinical nurse specialists and nurse practitioners who are trained, really, in counselling methods, really. But to answer your question, as a specialty in Australia, it is not recognised as a specialty. You don't train in cardiometabolic medicine. That may change. The closest it comes to is maybe a pathologist who has an interest in lipid disorders, who may train in endocrinology, or a cardiologist who has an interest in prevention, who trains in hypertension and also in lipid disorders. So it's, I mean, I see it the way we have tried to define a curriculum. We have tried to go to the colleges and say, here's a specialty in cardiometabolic medicine. What do you advise? And at the moment, really have to say, it doesn't seem to fit in any training program. So what we have advised that if you want to do cardiometabolic medicine, and there's a tremendous role for this, both in the private and the public sector, is that you choose a specialty that you're going to do. For instance, it could be general medicine. So one of the consultants that we've developed in one of the hospitals, she trained in general medicine. She runs her clinic out of general medicine. And from there, she's had some training in hypertension, lipid disorders and prevention, and that's how she runs it. So you create, as it were, your own cardiometabolic domain, as it were. The other clinic run at another teaching hospital is actually a cardiologist, really, who's interested in prevention. So he's trained in imaging, he's trained in lipid disorders, and a bit in hypertension. So he trains that. That goes into the specialty of cardiology. The service that I run, well, I'm effectively trained in cardiology, diabetes, general medicine, and I've run it like that, really. But it did take some time, actually, to break down the barriers and recognize where the specialty should be, actually. And the tipping point, Laura, was FH, because this is effectively a high-risk cardiac condition, really. So when you had to go to a business manager and say, look, we want to set up a new service. The central feature is going to be FH. It's a cardiac condition, and we're going to prevent, and treat people, so that they don't get a coronary event or get a secondary coronary event. They said, put it in the Department of Cardiology. So, that's where I think it belongs in cardiology. You don't have a separate department of cardiometabolic medicine because it goes across all the specialties per se. But I think it belongs primarily in cardiology or diabetes, right? In there, it's a question of what the circumstances are in that context that will enable that to develop. I don't think it belongs in renal medicine. I don't think it belongs in hepatology, although I have an interest in NASH or non-alcoholic, or MASH as they call it now. And I don't believe it belongs specifically in general medicine. It's probably cardiology, endocrinology, diabetes. But if those are your primary specialties, then you've got to do something else. What do you how does it work for you then in Romania?
Well, I think it's different in each of our countries that we're listening to. And I think I see this tendency where we start to have a lot of joint events and we start to have training in both. So some teams in cardiology, some teams in diabetes. And I love that we put also basic research and clinical application. And I also loved that you said about this clinical significance or clinical meaning that you're actively searching in your work. So I would like to have a question regarding FH, and what steps would you think would be necessary for implementing a successful national strategy, or what would you advise clinicians or researchers who want to work more in this field? What should they do? Where should they start from?
Well, I think, it's all to do with training, isn't it? So I think you've got to have your national bodies, your colleges for training in agreement about how this is going to happen, actually, because, you can't train. You've got to have some sort of training. You've got to have a badge that says, I can train as a physician, really. So consult your colleges, consult your colleagues, set up a national consultative meeting, and decide what you want to do. Now, implementation is all about it's a paradigm-shifting thinking for making something happen after you've got some evidence. So after you've got agreement, really, on something, whatever it is in the context, then you try and implement that. The example that I gave you was really just me implementing something, taking an opportunity of looking as FH as a model for what would be the central feature of the service, and then you build that around to the extent, really, that, we have appointed, senior lecturers in endocrinology with an interest in diabetes and experts in hypertension. But at the moment, my advice is that you get national agreement on what the specialty should be. And after you get national agreement, actually set up an implementation plan. So an implementation plan is looking at, what the barriers and enablers are for what you want to do, and then find out solutions, find out and identify solutions about how you can use those enablers and barriers to get to where you want to be, actually. Now, that's a generic approach that you can use for implementation. It's called implementation science, really, which can be applied to a clinical service. It could be applied to a model of care. It could be applied to a training program, actually. So there are sort of certain tools that you can use, actually, to implement something. But it doesn't stop there. I mean, after you have implemented something, then you got to assess how well you're doing it with all your outcomes. It could be it could be set up a new education program. It could be setting up a new clinical service or quality assurance program. And then when you assess those impacts, then you've got to fine-tune them to improve it. And if things are going well, the greatest challenge is sustaining the change that you've made, actually. I mean, you ask a key question, really. How do you implement? And implementation of anything is changing a behavior, actually.
Yes.
And I think at the moment, with respect to anything, whether it be a new program in cardiometabolic medicine or a new program in familial hypercholesterolemia, something's got to change, right? It's all about change. And change is complex, really, isn't it? Because change involves, it's in its own right, this is what behavioral scientists do, is to, analyze what the determinants are of the factors that control that change. That's the only way you can bring change about. And again, there are tools where you can address that, really. There are tools from behavioral psychology and implementation science that address those factors. Basically, overall, you're trying to, certainly in clinical medicine or in a service, whatever you do, you want to change, capabilities.
Yes.
You want to change, the opportunities that people have, and you want to address, motivational factors.
Yes, it was like in the talk that you had yesterday, and I'm very happy that these are still on the EAS platform for a few months after the Congress.
That's an example. Yes. I'm glad you read, because that's now quite a major interest of mine. So I call it complexity science, really. How do you actually deal with complexity science? How do you address gaps in care? Now, there are gaps in care of everything, actually. Diabetes, hypertension, coronary disease, management of post-ACS patients, and familial hypercholesterolemia. I mean, what I realized not so very long ago that, government could bring about a change, making genetic testing available for familial hypercholesterolemia, and then that was reissued into a population, really. And no one was ready for that. The doctors weren't ready for it. The patients weren't ready for it. And that's not the way how to start something new. I mean, you have to... this is the value of implementation science, really, that it's a science that's only 20 years old, actually. And it arose out of the need to think differently about how to improve services, really. And it's something you can apply to anything when you've got a problem, actually.
Thank you so much for your insights. So now in our final minutes in this interview, I would like to ask you if you have any advice for our listeners, many of which are young clinicians and researchers that are finding their own path in the research of atherosclerosis.
Well, you have to be interested in what you're doing. Be humble. Be firm. find some good mentors, and learn how to collaborate. It's very important. Don't feel too threatened by others. I know you're probably all in competition, really, but competition is good, but I think you have to think collectively, and with equanimity. But these are human factors that will make you a better person, really. Keep your research relevant. Always ask, the clinical research, every research that we do, it's centered on one thing, and that is, is patient-centric. It's what value, ask the question, what is the value of this, for the patient, really? And that's what we're doing for people, for humanity. This is what you want to improve. Keep yourself relevant all the time by asking that. And if you're not clear what it is, speak to your mentors, actually. Now, the other thing I would say that is not done particularly well is think about what you're thinking about, really. Teach yourself how to think. There are methods of thinking, and I would always advise, and I always advise my young PhD students and master's students and doctoral students and postdocs to actually get some training in methods of thinking and the philosophy of science, actually. So what are you actually doing in the philosophy of science? These are the methods of thinking about the process by which we investigate. I do find in my time, it was very, very important to have a hypothesis-driven scenarios where from there you inferred, as it were, by deduction, sub-hypotheses that you actually tested. Because the reality is what you're just testing specific instances of hypotheses, in the laboratory, in the clinic, from when you can induce from that by the method of induction and a generalization about a much more general hypothesis. So I think in education or in thinking about what you're doing and the generation of hypotheses and the inductive process. A lot of the things that I often worry that people tend to overstate, the young people tend to overstate the importance of their findings. The findings from your research are nothing more than inductive generalizations, really, meaning to say is you induce to a greater world, as it were, to a greater message. But in fact, really, the certainty in that particularly induction process is quite small, actually. So you have to obtain advice on that. In terms of writing a paper, I find that many students come to me not knowing how to construct a paper, actually, and in particular how to construct a discussion. And there's a particular structure for doing that, really, given the top lines, interpretation, comparison with other studies, and what other studies should you be doing. But these are the two things I want to say specifically about advice about writing a paper that I find with young investigators that they are not, in general, particularly good at it till they encounter me. One is you have a paragraph on what the limitations are of your study. And I remember with the young students saying, well, tell me why your study's so bad. And they look at you as if, bad? This can't be bad. Every study has profound limitations, right? So my advice is keep yourself humble by assessing and talking about what the limitations of what you're doing. Now, the next thing I want to say, and this is the last thing I'd say because I know you want time, Laura, time's running on, is every scientific process, whether in medicine, physics, or whatever, goes from discovery to creation of a new problem, right? So having reported your findings, having interpreted them, having assessed them for limitations, ask yourself a question, what is the next question? That's the way science progresses.
That's brilliant.
It goes by steps. It's the creation, you do something to create a new problem, which you set up as your next approach. And again, that's another limitation. That's another limitation I want to raise. Look at your studies quite critically, deconstruct it yourself and build new questions for the future.
Thank you so much, Professor
Not
Watts.
at all.
It was really an incredible interview. And also I would like to give a big thanks to our listeners, because this podcast is for you and we need your feedback to tailor it to your interests. So please don't forget to leave us your impressions. So then until next time, please stay curious, stay inspired, and thank you so much for listening.
Well, the pleasure is mine, actually. Thank you.